Hello everybody and welcome to the Combinations podcast, the podcast from North Staffordshire Combined. And today we're going to be raising awareness for Delirium Awareness Day. And I've got a few guests from the clinical side, and I've also got Claire Tallentire, who is part of the communications team as well, to tell a story. I don't know if you want to go around and just introduce yourselves and just say what sort of role you do in the trust.
My name's Rachel Massey. I'm a nurse practitioner with a team called the Care Home Liaison Team, and we support older people living in care homes where there may be some mental health concerns.
My name's Lucy Powell. I'm one of the critical care rehab coordinators, and I work at UH&M supporting patients and families as they recover from critical illness.
Hi there, I'm Claire Tallentire and I work in the communications team here at Combined Healthcare, and we help to profile and tell the stories around combined healthcare and what we're doing. And I'm here to share a story about my father and his experiences of delirium.
Okay, so obviously, as Claire mentioned, we work in the communications team and we do awareness days, and obviously the 15th of March this year is obviously our Delirium Awareness Day for Delirium. We've done it previously at Combined, raised awareness. We did some virtual reality films, we did some packs to raise awareness, and this year we thought, well, let's go again and raise more awareness to delirium, and we're doing this podcast to sort of, I don't want to say celebrate, but to make people more aware of delirium, because it's one of those things, when you spot it, you've got that knowledge to sort of be more adaptive. But I don't know if, Rachel, you want to just explain what delirium is, like in a simple way?
So delirium often can be misdiagnosed or misperceived as being dementia, but they are quite fundamentally different. You can have dementia and you can have delirium together. But how I sort of try and explain it is whereas dementia is a chronic brain injury, so that's it's ongoing and gets progressively worse. When you're looking at delirium, you're looking at an acute, sudden onset of symptoms that aren't necessarily in keeping with what you'd expect to see with a dementia presentation. So the individual may present with sudden changes in behaviour, they may become very withdrawn, they may stop eating and drinking, they may stop sort of functioning at their normal level. And again, sometimes that can be misperceived as being perhaps a depressive episode. And sometimes people can present with increased agitation, symptoms of aggression, hallucinations, becoming very confused. And another feature can be that presentation can fluctuate, so they can sort of have times when they're more calm and more lucid, and you can engage them in what would be their normal conversation, and then they become very confused and agitated again. So you can see quite a mixed presentation. But generally speaking, what we're seeing with delirium is a more acute onset. So, last week they were absolutely fine, and then, almost overnight they can be very changed in the presentation, and that would be one of the first things we'd be questioning at that point.
And is delirium classed as a diagnosis then?
There are tools that help to diagnose a delirium, and I think it's really important to know what it is that we're trying to treat. And I think it's shifting it away from being perceived as being a mental health problem. It's really quite a serious condition, and if the individual isn't given timely support to help to reduce those symptoms and the impact of those symptoms on them, it can be life-threatening, and there is an increased mortality rate associated with delirium. So there are diagnostic tools that you can look at to support that, but generally I think most clinicians would kind of be able to take a good history that would enable them to sort of conclude that the likelihood is this is a delirium that we're treating. And I know Lucy will support this much more so than my experience. It's quite complex as well, because often it's not just the delirium that you're trying to treat. There are other things potentially going on as well. So it's unpicking that and trying to look at what's sort of causing what, really.
It's very interesting, isn't it? And I've only known delirium for about a year, and I've obviously in and out of it. I don't study it every day, but it's one of those things that I do find quite interesting that goes on. And you hear stories crop up here and there, even from family members when they've talked about one of their family members has been ill, and they said, "Oh, they did this," and it does sort of sit in the back of your head, going, "That does sound a bit like delirium," but I'm never clinical enough to know or to do anything about it. But it is interesting that it does sort of crop up here and there, and I think that's what's, raising awareness is why it's important, because now I've got that knowledge and I've only spent probably a day and a half like just actively talking about it, and I've got those skills I want to say for life. You mentioned that acute is where it's mainly found, and obviously we've got Lucy here today who can talk about her experiences about delirium as you work in the acute setting. The question I want to ask, though, is who is more likely to experience delirium? Is it anybody, or is it mainly the older generation, or is it people with underlying conditions? Who's more likely to experience delirium?
So delirium can affect absolutely anybody, and there's lots of different causes. Anybody can be affected. I work in intensive care, so we were chatting earlier, weren't we, Carl? But 75 or up to 75% of our patients can experience delirium at any time during their time in intensive care. So those statistics are pretty scary, really, and it's something that we do a huge amount of training on, just to support the staff and to be able to identify delirium as quickly as possible. There's a lot of what we try and do is to encourage the staff and also relatives and visitors for the patients to support them in a sort of non-medical way, because actually lots of people think there might be a sort of medicine that you could give a person to recover from delirium, but actually staying away from medications is probably one of the best things you can do. Obviously, if it's an issue associated, if the patient is a risk of harm, then you may have to use medication. But in the vast majority of cases, it's just about explaining lots of orientation, so explaining to the patient about where they are and repeating that information in a friendly and not sort of repetitive way, but just regularly reorientating them to where they are and why they're there. It's about normalizing those experiences as well, and explaining that it is a normal part of being in hospital. Even for a patient, it's really common for patients to experience this condition and not to be frightened of it, though it can be really frightening for both patients and their relatives. It's about lots of reassurance and explanation of why this can happen, because it can be associated with so many different things, such as not being in familiar surroundings, being unwell, whether that's an infection or maybe something, surgery or whatever. There's so many different causes, but essentially patients have been taken away by being in hospital. They've been taken away from all the things that make them feel safe and grounded, their normal environment, and that can be very unsettling to them and their brain and how their brain functions. So it's about trying to reintroduce things that are normal for them so that they can feel safe in an environment that they don't feel safe in. So reassuring them that they are safe is really important, but also bringing in familiar things from home. So whether that's photographs of people that they love and familiar settings that usually if they've got a dog or their lovely garden or what have you, so that they've got something that you can distract them with and talk about that rehumanizes the environment that they're in. Getting patients into their own clothes as quickly as possible is another really important thing, because that familiar smells and senses and sensations is really important to help ground them. We try and encourage patients to go outside as quickly as possible as well, because the hospital environment is really frightening, and actually using the green spaces, the lovely green spaces and gardens. We're lucky enough at the Royal Stoke Critical Care to have a rehab garden, which is lovely, and we try and take patients out there as soon as we possibly can, and it's safe to do so, so that it's a distraction and they can talk about other things other than how unwell they are in the scary environment, just to try and alleviate some of that anxiety and normalize their experiences. So
I can see why people compare it to dementia if you're taking photos in and things like that, because that's another way of like helping dementia patients take older things in. That's more about memory recall for them, but you can sort of see that they are not similar, because we are trying to distinguish the two, but how like doing normal things brings almost like your mind back around to its normal state. I think that's what it is. It sounds like your brain just gets so numb in the environment it's in. One question I do have for you, Lucy, is, you say 75% of patients on your ward will get delirium. How frequent is it in your work week? Is it daily? Is it weekly? Is it one every month? How often do you experience it?
Absolutely. So, and I know Rachel touched on earlier that it can be a fluctuating thing. So delirium can come and go, but any one of our patients at any time could be experiencing this acute confusion or delirium. So often patients may experience something called sundowning as well, which again is common in dementia patients, but it's something we see a lot in intensive care and in hospital, that patients are more settled and lucid during the day, but as that transition to night time, sometimes that confusion can really sort of set in, and people can become quite distressed and agitated. I wouldn't know the statistics, but I know that most, the vast majority of our patients will at some time experience delirium, certainly.
And is the whole ward ready to go? If they see a patient, they're all ready to help out and sort of...
Absolutely. So we're assessing our patients every 8 hours for delirium, and we're lucky we're at the bedside, all of the time, really. Our patients are very rarely left for any period of time on their own, and so we're constantly monitoring them, really. But the formal assessments are done every 8 hours in intensive care, and that's quite different to the ward setting. I think that's important to recognise. And so my team, we support patients when they move to the ward setting as well, and those assessments are perhaps done less regularly, but there are lots of tools out there to support the assessment of delirium in those patients. So yeah, it's a constant monitoring and support process. I think it's about from our perspective, it's about identifying the patients that are at risk of delirium, and when they do have delirium, getting the right people in place to help support them. That's an MDT responsibility, really, as far as we see it. So obviously the nurses and medical staff have all had training in how to identify and support patients with their delirium, but we rely really heavily on our therapy staff as well, occupational therapists and clinical psychologists in particular, just to help patients with that orientation and normalization process. We want to know what helps our patients to tick. We want to learn about them as individuals so that we can support them in their recovery and help reorientate them. So we complete documents such as the All About Me, which lots of people will come across in hospital, hopefully, which is where families and relatives are given the opportunity to tell us and write information down about that patient, so that we know, well, they really love their garden, or they love to watch the racing on the telly, or what have you, and we can incorporate that into the conversations we're having and the stories that we're telling with our patients to help them feel safe with us, and hopefully help them to recover from delirium as quickly as possible.
And I think just jumping in on that point as well, I think it's important to recognise that the delirium recovery isn't necessarily going to be in place for when that person's discharged from hospital. So they may be medically fit for discharge, but they may still be recovering from the delirium. And we know that delirium can persist for, quite a significant period of time after what the underlying cause has been treated, and I think that's part of the work that we're doing, certainly with the care homes. I think they think there's this perception that once somebody's been discharged from hospital, they've not got an infection anymore. Whatever was causing the delirium's gone. It must be something else. And I think that's part of supporting that patient's recovery, because the more effective that recovery process is, the better their recovery will be, because sadly some people don't return to their baseline. Certainly it also increases the individual's chances of going on to develop a dementia in the future as well. And I think we need to be careful of not assuming that person's baseline when they're discharged from hospital is their optimum. So I think we've got to take we've got to look at it from a number of angles, and all the things that Lucy said about familiar items and anchoring people in reality. Yes, with dementia, you'll use photos and things like that for reminiscence, to use happy memories and take people to perhaps the stronger memories at that time in their life. But what we want to do with delirium is to support that person to be orientated to the here and now. And again, picking up on the words you use, Lucy, very much, is safety in capital letters, because when the individual is becoming agitated and maybe become aggressive, it's a fight or flight thing. That they're feeling scared, they're backed into a corner, they're defending themselves. And we've got to do everything we can to support those individuals to feel safe. But likewise, those who are perhaps having a hypoactive delirium, so they're more withdrawn, they're not causing anybody any problems. So there's a risk of them quietly just fading away into the background. And those are the ones where there is a significant risk of physical health deterioration, because they start to decompensate. They're not eating and drinking, and it makes them more at risk for things that will prolong their recovery, and at risk of infection again, and so on. So it's quite a complex process that doesn't end once they're medically fit for discharge from hospital. So that's where our support and our work lies with the care homes, really.
And yeah, it's a very good point. And obviously, you pair are very experienced with delirium. And Rachel, you just mentioned about patients, coming out of hospital and going back to the care homes. What are good signs to sort of tell, anyone to sort of look out for when delirium is around? What are the easy signs to spot?
I guess one of the things is, what's this individual's baseline? So we talk about how this person normally functions, and if how they're functioning is significantly different, that's kind of a bit of a red flag potentially. And again, it's difficult when somebody's been in a hospital setting with the best will in the world, they're in an unfamiliar setting. We become patients within that environment, and we fall into those routines. And I think it's about helping that individual to get back to their normal level of function, their normal routine. So I think anything that stands out as being different from what this patient's normal level of functioning is, as I say, quite often with the hypoactive deliriums, that those individuals can easily kind of be overlooked because they're not causing anybody any problems as such. They're not, becoming physically aggressive and so forth. And again, it's about the ongoing process around supporting their sensory needs, optimizing all their fundamental needs, ensuring that pain is managed, that they're getting sufficient hydration and nutrition, that they've got the hearing aids in and that they're working, that they've got the glasses on, that the lighting is conducive, that they've got all of those things that are supportive, the mobility aids, so that they're not sitting in a chair feeling unsafe about getting up. So there's a whole raft of stuff that the care homes can be doing to support people. And again, as I say, if they're kind of feeling actually there's a significant difference between how the patient was and how they are now, then that's where we need to be questioning, is there still a delirium ongoing?
So it is looking for the behaviours of the patient, and obviously family members would know that instantly if they're like, my dad's not behaving how he used to. That sort of could be a sign of delirium. So
definitely,
I think generally it's that focusing on things like the confusion element, and we've touched on it already, haven't we? But like Rachel was saying, changes in personality. Some people can get quite paranoid, so they can be really frightened of the staff and people that would normally be reassuring to them. They can be really agitated, have behavioural changes. They can be in that hypoactive delirium. They can be, like Rachel was saying, really withdrawn and very sleepy. It's just the brain's response to delirium is sometimes to hide away a bit, and they can be rambling in what they're talking about, really distractible, so you just can't hold a conversation with them in the same way that you would do normally. So yeah, all sorts of different signs and symptoms that people can be looking out for. But I think Rachel's absolutely right. It's important to remember that how the patient presents when you meet them for the first time may not be their normal behaviour, and I think it's really easy for people to fall into that trap and assume that if somebody's confused, they're always confused. And we're often saying, no, this person is normally fit and well and independent. You know, we need to stop thinking about them as this confused, unhappy, frightened person, and remember that they like going to the shops and they love Star Trek or whatever it might be, you know, that they're a person, and actually how they are presenting at the moment is not their norm, and we need to help to get them back to being their normal self again. And that, you know, vast majority of times does happen. I think that's a real worry for friends and family, that these changes that they see in their loved one are going to be in the long term, and that's not the case. And it's just that they're unwell at this time, and delirium is all part of them being unwell, and that if we help and support them and reverse all those causes of their delirium, they can make a full recovery.
And we brought Claire here today to tell her story, as we'll find out. As Claire mentioned, that when we did Delirium Awareness Day last year, she got involved, she picked up some of the signs and has come forward and basically said, I think I've spotted delirium, and she's here to tell us a story. So do you want to tell us your story, Claire?
Thank you. Yes. So my dad was in hospital for in and out of hospital for quite a prolonged period from November 2021 to May 2022. In a hospital, not in this region, outside this region, and also in a ward setting for cancer treatment. So, and he was in his mid-80s as well. So he was in and out of the hospital quite a lot from home. And I just started to notice a change in him, which wasn't my dad. So things like he was always quite a laid-back person, very placid, but his temperament started to change. He was getting quite angry, quite confused at periods. When I spoke to him over the phone, because he was quite away from me in terms of me being able to visit each week, he was slurring his words. He was getting confused between me and my sister. And it was just, to me, it wasn't my old dad, really. So I started to question, is this normal within a hospital setting, or is this something else? And I had started to do some work in the communications team around World Delirium Day last year, and there was an excellent resource on Think Delirium that was put together through the delirium support team here as well, and at UH&M, which just maybe start to question whether what I was seeing was delirium. So it gave me the confidence to actually have that conversation with the nurses, and also when he was out of hospital too, the support he had in home as well. So it was something that I spotted, and I did pick that up with the nurses and with the support at home, and they did support that it was a period of delirium that we were seeing. And it was just those subtle changes that we could make to support my dad, which we talked about. So things like when he next went back into hospital, making sure that he had pictures from my 7-year-old daughter around his room that he was in for quite a while, just to support him. Knowing that my dad really, really liked, he's a massive Torquay United fan, so just talking to him about football, the TV programmes he liked, that to kind of reorientate him back into the hospital environment when he had to go back in. But certainly the resource that we had on Think Delirium was so helpful to me to enable me to have those conversations with the hospital and to take that subject up with them, really. So thank you for that resource and allow me to do that and to have that conversation.
And thank you for telling your story, Claire, because it's obviously not easy when your dad's in and out of a hospital. If any of you are interested in seeing what it's like to experience delirium, we created a VR film, which is a virtual reality film, which you can use with a headset, or if you don't have that, you can use a mobile phone. You can go onto the Combined's YouTube channel and you can find the virtual reality film there and see what it's like to experience delirium as a patient. We've used this film to help raise awareness and sort of use it as a training tool for our staff to spot delirium much efficiently. So you can go on there and experience our VR film. Obviously, we've made this podcast today to sort of raise awareness again. I don't want to say it's year 2, but it's definitely the second year that we've got involved, and we want to keep doing it every time it comes around, because it is something that we want to get out there so you can learn and spot the signs of delirium. Is there anything that Lucy or Rachel you want to add about delirium that you think is important for anyone to know?
Just one little point was around the individual with the delirium often can remember the delirium. They can remember how frightened they were. They can remember the experiences. I know my own dad had delirium, and he can remember all of the emotions he was feeling at that time, and the overwhelming fear and distress, and sometimes, you know, it's really important to remember that what we're doing at that moment can have such a big impact on how that person recovers from the delirium, because psychologically it can be very difficult for the individual as well. So I think that's another sort of an important point to make.
Absolutely. And I think if you've got any concerns about your relative, you know, friends, relations, what have you, and you think that they may be experiencing delirium, then you must seek medical advice to help address that and get it sorted as quickly as possible.
Just remember, 15th of March is World Delirium Day, and use that day to raise awareness with yourself and others about delirium. Thank you so much for listening to this podcast. We hope that you've enjoyed it. If you want to find links to the virtual reality film, that will be in the link description of the podcast. And this podcast, of course, is available on SoundCloud, Apple Podcasts and Spotify. Thank you to my guests who've joined me today, and thank you, Claire, for sharing your story. And we hope that you've enjoyed this Combinations podcast.